and it's successful and it's very unforgettable. Then we wait for the next training for level 2 of group 1 next year, maybe around April and May. And also we opening for the registration to second group for join us to next year level 1 ISST training. So we welcome to our speaker. Maybe I'll give back to the host now, yeah. Okay.
Oke, terima kasih untuk Ibu Susan atas perkenalannya mengenai metode SCORT ya, Bu Susan. Semoga pesertanya nanti setelah mendengar presentasi dari para pembicara bisa mengikuti pelatihan training nanti ya untuk yang kedua ya. Baiklah, untuk pembicara sudah masuk, kita akan masuk ke acara. Okay, good evening, ladies and gentlemen, and all health professional. My name is Dina Widyaningsih. I am part of Physiotherapist Division in Bogor. Welcome to Health Event ISST Sport Germany and Pervi Kota Bogor Seminar Online International. We have an interesting discuss this evening that about multidisciplinary approach in the treatment of idiopathic scoliosis. And of course, we have speaker that was much experience in healthy division. It is now my pleasure to introduce our guest speaker, Mr. Nikola Jeftik, Dr. Samra Janik, Mr. Oti Lumbonir Metik. And for the next step, I will give it to our moderator, Mrs. Susan and Mr. Raden Galuh. Please, pleasure. Thank you.
Hello. Could you hear me?
Yeah, hello.
Hello.
Hello, Nicola.
Hello.
How are you?
Can you? I'm fine, thank you. How are you?
I'm fine, thank you. In the first step, I will give moderator with Miss Susan. Mrs. Susan, yes. Miss Susan, maybe the signal is not good at her home.
Can you see me?
Yeah, Miss Susan, hello.
I can see you, Nicola.
Okay, everything is fine? Can first start Dr. Samra?
Yes, Nicola, I can hear you. Good evening to everyone. And I was told that the moderator will have an introduction, but I can also do it by myself.
Okay, wait, Dr. Samra. Thank you for joining us. Wait.
Thank you.
Oh, Galuh. Galuh, can you start first?
Okay. Susan. Okay. Hello, good afternoon. Hello and welcome, everyone. Thank you for joining with in the webinar session. Let me introduce myself. I'm Galuh Gurmadi, and I will be moderator in the first sessions. Okay, in these sessions, we will talk about the multidisciplinary approach in the treatment of idiopathic scoliosis by Dr. Samrajanik. Dr. Samrajanik is one of the scratch instructor for physician. In this session, I will give Samrajanik to completely her presentation, and after that, I will open the discussion. And for the quick notes, I want to give some kindly reminder. First, please mute yourself during the presentation. Second, the session will be recorded, so be aware to turn off your camera if you don't want your video to be shared in social media later on. Third, in the end of presentation, we will open to discuss, and you can put your question in the chat room during the presentation. Before we start in the first materials, I would like to introduce Dr. Samrajanik CV. Wait a sec. Dr. Samrajanik is a PRM specialist and has been working in the Institute for Physical and Rehabilitation Medicine, Dr. Miroslav Zotovic in Banja Luka, Bosnia and Herzegovina since 2011. She graduated from the Faculty of Medicine in Sarajevo, finishing her master's degree in medical science in 2010. Since her work is focused on the treatment of pediatric patients, especially children with spinal deformities, she completed an education in scratch therapy in the Asklepios Clinic in 2013 in Germany. Thereby, becoming a certified scratch therapist. In 2019, she attended a refresh course in scratch therapy in Novi Sad, Serbia. Last year, she became first international ISST instructor for physicians. Additionally, she is working on her PhD thesis on the effects of Keno-Soberheim brace in the conservative treatment of idiopathic scoliosis. Now, without further ado, we will turn to our speakers. Please welcome Dr. Samrajanik. To Dr. Samrajanik, time is yours.
Okay, thank you very much. Good afternoon or good evening once more. Thank you for inviting me and organizing this webinar. I think you will get some basic information and understanding about the conservative treatment of scoliosis, and hopefully you will be able to, or you will be stimulated to have further education about this. So I will be taking the doctor's part, so to say, about the assessment and diagnostics, and Nicola and Yuba will then lead with therapy options. I will now share my screen. Just a second. Can you see the presentation?
Yes.
Yes, we can
Okay,
see
great.
your presentation.
Okay, great. So, first of all, I want to emphasize that we will not talk today about functional scoliosis or so-called postural dysfunction. We will focus on structural scoliosis. That is a 3D deformity that is in 80% with unknown cause, and it is called idiopathic scoliosis. And in 20% of all cases, it is secondary due to different underlying diseases and pathologies like neuromuscular diseases, congenital, different syndromes, and so on. So we will focus on the structural scoliosis. When we talk about definitions of scoliosis, there are way too many. What is important for you to know is that it's actually about structural changes on the spine, so on the vertebrae, where they become rotated, wedged, and compressed. And also there are changes in the discs between the vertebrae. And another thing is that we cannot talk about scoliosis if we don't have the X-ray of the spine. So in order to diagnose scoliosis, you need to have the X-ray, and according to the SRS and their definition, scoliosis has to have a Cobb angle at least of 10 degrees. Of course, there are some cases where we can diagnose scoliosis even if the Cobb angle is below 10 degrees, but we need to have important rotational aspects in the spine. So vertebral rotation has to be present. The spinal deviation that occurs is followed by typical trunk deformities. And the most important thing we need to know is that is a 3D deformity, because in the previous decades, the scoliosis was observed as a little bit as a 2D deformity mostly, so lateral deviation in the frontal plane and rotation in the transverse plane. Fortunately, in the last 15 to 20 years, many researchers has shown that the sagittal plane is also important, and that scoliosis actually starts from the sagittal plane. So when we have a thoracic hypokyphosis and lumbar hypolordosis, and also sometimes hyperlordosis in the lumbar sacral junction, it is very important for us to guide our treatment option and to make a prognosis of the deformity. So you always have to look at the scoliosis as a 3D deformity and to treat all the three planes. There are many scientific societies lately that are dealing with scoliosis. Mostly we will talk about the SOSORT organization because it gives us guidelines for the conservative treatment of scoliosis, but also SRS, as American Organization of Orthopedic Surgeons, is also very important. And you can see here also some other societies listed. When we talk about scoliosis, the term actually goes back to ancient Greek, first mentioned by Van Galen. Scolios means curved, crooked, and Hippocrates talked about spina luxata. Incidence, there are different numbers of incidence in the literature, but most commonly it's about 2 to 3%. And about 10% of all these cases require conservative treatment. Fortunately, only small percent require surgical intervention. There is also a difference in the prevalence according to the latitude. So there is higher prevalence in the northern part of the world, according to Dr. Grivas, and it is actually connected with sun exposure and melatonin levels. Girls are likely more affected than boys, especially when it comes to larger curves during puberty. We will talk a little bit later about the possible reason for that. Idiopathic scoliosis with the unknown cause, according to the age of first detection of scoliotic features, can be divided into 3 groups. So we have infantile idiopathic scoliosis, age 0 to 3. More boys are involved here with left thoracic curve and thoracic kyphosis. What is characteristic for this type of scoliosis? It can be reversible, but also progressive. Then there is juvenile scoliosis, age 4 to 9, with a very poor prognosis. Typical features that more girls are involved with typical right thoracic and left lumbar curve. But due to a very early onset, so this scoliosis occurs at a very early age, so there is a large risk of progression for this type of scoliosis because there is a great period of growth in front of those children. So prognosis of juvenile scoliosis, it doesn't look that good. And there is also adolescent idiopathic scoliosis from age 9 or 10. This is so-called late onset scoliosis. It has the same features as the juvenile scoliosis. When we're talking about assessment of scoliosis, it has to include the anamnesis, that are information and data from the parents and from the patients, then physical examination and clinical assessment, and also radiological assessment, if necessary. In anamnesis, what is important to ask the family? First of all, if there is spinal deformity in parents or in other family members, because etiologically scoliosis is a genetic disease. So it is observed that if father or mother have scoliosis, the child has a chance of about 20% to also have scoliosis during the childhood. So it's very important to have this information. Also, the onset of scoliosis, what I already mentioned, the age of the patient when scoliosis occurs, birth and developmental history in terms how the development in the first year of the child was. So if there were any abnormalities during sitting, walking, stability, and so on. Menarche in girls, we will talk later why is it so important. And of course, exclusion of other diseases and health issues, because we want to make sure that it is idiopathic scoliosis and not the secondary one. In physical examination, first, we need to make the patient ready for the exam. That means the patient has to take off the clothes. The trunk needs to be free of clothes so we can observe and see all the clinical signs and features of scoliosis. Of course, we also have to look at the skin of the patient because sometimes we can observe cafe au lait stains, for example, which lead us to neurofibromatosis. So it's important to have the observation of the trunk very detailed, and then we can do the plumb line measurements in order to see if there is disbalance in frontal or in sagittal plane. Height and weight measurements, very important during every follow-up to catch the growth spurt and actually to recognize the start of the puberty when we expect the most progression of scoliosis. Adams forward bending test, it's pathognomic for scoliosis, as you probably know. It's important to differentiate functional from structural scoliosis, but also to measure the angle of trunk rotation. We can see like thoracic hump or lumbar prominence with scoliometer. And when we have measurement on scoliometer 5 to 7 degrees, we can be quite sure that it is structural scoliosis in the patient. So it is actually indication for the X-ray of the spine. Neurological assessment also has to be done to exclude underlying diseases that cause secondary scoliosis. And we must not forget upper and lower extremity assessment, because if the patient has joint laxity or hypermobility, it has additional risk for scoliosis progression. And also leg length evaluation. Why is it important? Because sometimes leg length discrepancy can lead to functional lumbar scoliosis, and with the adequate shoe lift, the scoliosis disappears. So this is why it is important also to do the leg length evaluation. Here you can see a practical approach scheme that you can find in SOSOR guidelines. SOSOR guidelines is from 2016, and it is actually, this paper has a free access. So you can go and see the SOSOR guidelines and also look up for this practical approach scheme. It gives you actually the therapeutic frame. So it makes it easier for you to know what to do with the patient with certain type of scoliosis, with a certain degree of skeletal maturity, back pain, and so on. Of course, it cannot make a decision for you, but it can certainly help you and guide you through the therapeutic options. And also there is another strength of treatment scheme where you can also see all types of treatment listed here and additionally explained. So now we come to diagnostics. First of all, screening and surface assessment. So clinical assessment, photography, trace and POTSI score. These are all useful tools, diagnostic tools. Then surface topography, we will talk a little more detailed about it. Radiological assessment, EOS, and ultrasound. X-ray of the whole spine is still the gold standard for diagnosing scoliosis. And when we first observe and assess the patient, we have to have two projections of the X-ray. So we always do the projection anteroposterior or posterior anterior to see two planes, that is the frontal plane and the transverse plane. But we also need to do the lateral profile in order to observe and measure sagittal planes, so sagittal curves and pelvic parameters, because we want to make sure not to deteriorate one plane in order to correct the other. So this is why we always have to have two projections, at least at the beginning and at the end of the treatment. When it comes to the frequency of the X-ray, every 6 to 12 months, X-ray can be made. Of course, if there is clinical deterioration, you can also do an X-ray a little bit earlier. But as you know, since it have oncogenic effects, we always try to do it as less as possible. And to assess quality of bracing, we do the in-brace X-ray, but we'll probably talk more about it. When we're talking about parameters on the X-ray of the spine, Cobb angle is of course the most famous because it defines the therapeutic option, it enables us follow-up and so on. But you must know that there are also other parameters that are very important to classify scoliosis and also to do the follow-up, like rotation, like coronal balance, transitional point, etc. So it's not only the Cobb angle that is important on the X-ray of the spine. EOS is a very good device, unfortunately very expensive, so only big centers, hospitals have the opportunity to buy it. I think it's about €500,000 or something like that. It has 50 to 80% less radiation than conventional X-ray, so this is the big advantage from EOS comparing to the X-ray. It has the opportunity, the possibility of 3D reconstruction of the spine also, and it's allowing measurement of torsional deformity, which classically requires a CT scan. But like I said, not too many centers can have it. In our center, we use Scolioscan, that is ultrasound device, for 2 years now. And the greatest advantage of Scolioscan that it is radiation free. So you don't have to think about how many times you can put the patient on Scolioscan like you do on the X-ray. So it is totally harmless for the patient, and this is why we're using it more often. Of course, in this stage, we're not able to replace X-ray, but we're doing the X-ray and ultrasound the same day at the patient, and then we're trying to reduce the radiation during follow-up by using more ultrasound than the X-ray. Also, 3D reconstruction is possible in the ultrasound. Kinect is a surface topography device. It is also radiation-free. It does the screening, it's like photography actually, doing the screening of the back surface. So it measures, it gives objective measures of different scoliotic features that we can observe clinically. So it's like objective measurement of the clinical picture of the patient, which is very good. It can help us in our assessment and our follow-up of the patient. What does conservative treatment include? Of course, it depends on type of scoliosis, but we can observe the patient. That means not to intervene, but only to wait and see what happens. It's just for monitoring of very mild curves or functional scoliosis. Then there is physical therapy with PSSC, physiotherapeutic specific scoliosis exercises like Schroth therapy that has evidence in the literature, so only evidence-based asymmetrical exercises can be used in structural scoliosis, and bracing for moderate and severe scoliosis that show risk of progression. Main goals of conservative treatment is to stop curve progression at puberty or possibly even reduce it. If we start our treatment right on time, then we have a great possibility to reduce the curve. This is my clinical experience. If we catch the scoliosis on time, when the children are small at early age, when they're still elastic and flexible, we can get the reduction. Then to prevent or treat respiratory dysfunction, spinal pain syndromes that occur in the adulthood, and also to improve aesthetics via postural correction, and all in all, to improve quality of life for our patient and to avoid surgery. So why is it important to have multidisciplinary team? Because we want to have successful outcome. We want to have a good results for our patient. You have to know that our patients are very vulnerable group. These are teenagers, and they're dealing with really hard treatment, bracing and everyday exercises. So it's important that every expert and every professional focuses on its part, on its segment of the treatment to be able to help the patient and their parents. So we need compliance, we need adherence to treatment. Without that, we cannot be successful. No matter how good the brace is, no matter how good the exercises is, if we don't have the compliance of the patient, we will fail. So this is why we have all the professionals, doctors, physiotherapists, orthotists, and psychologists to help the patient and to have a successful treatment through the years. Now we will talk a bit about scoliosis progression, how to identify risk factors and how to assess the risk of progression. For me, this was, as a doctor, this was actually the hardest part, but it is important to know it for the assessment and follow-up of the patients. You have to know that progression that occurs during a growth spurt is a vicious cycle. So once the asymmetry occurs, asymmetric loading leads to postural and structural adaptations, and then we get structural changes on the spine, and it goes around in circle, and it gets worse and worse during growth spurts. So our goal is to stop this progression early on. Etiologically, there are many theories, but none of them was proved as the one that causes scoliosis. It is assumed that multiple factors and polygenetic interactions lead to systemic disorder, disharmony between autonomic and somatic nervous system. How do we define progression? You have to have an X-ray to define progression. So 2 X-rays, as you can see here, within 1 year, where we measure Cobb angle and see that there is increase in Cobb angle more than 5 degrees. We can say that this scoliosis in this particular patient progressed. When do we expect the most progression? As you can see here, this is this period of maximum progression. It is puberty. So the puberty is not just one point in time. This is the whole period, 2 years, where we expect the maximum progression. And this progression is related to rapid growth. It lasts about 2 years, so we have to catch the patient right here at the beginning, at the start of the puberty, in order to have a good treatment for this patient. A little bit about pathomechanism, just shortly. I already mentioned how important the sagittal plane is for occurrence and progression of scoliosis. Rasso effect talks about disproportional growth of the anterior and posterior columns, and it actually contributes to impaired sagittal profile, reduced thoracic kyphosis and lordosis. And a positive correlation was found between the severity of the scoliotic curve and the extent of this anteroposterior disproportional growth. And this progression and vicious cycle is due to Hooter-Folkman law, where you can actually see at this part where the compression is, it's inhibition of growth, and on the convexity, there is additional growth. So the wedged vertebrae becomes more wedged and structurally changed. There is also dorsal shear force concept that is many are talking about in the last couple of years, that actually impaired sagittal profile leads to rotational instability and so leads to scoliosis. It's a reversion of shear forces. So they're normally anteriorly oriented, but when they're dorsally oriented, it starts with rotational instability and we get scoliosis in patients. What are the most important factors for scoliosis progression? You have to know. So first of all, it's a curve pattern. And thoracic curves tend to progress more during puberty, especially if there is reduced thoracic kyphosis or lordosis. There is so-called lordoscoliosis in the thoracic segment that is very progressive. When it comes to double major curves, the lumbar curve tends to progress more. If you observe left thoracic scoliosis in the patient, you need to think about the neurological underlying disease. So MRI is recommended. It can be situs inversus, it can be syringomyelia or Darnold-Chiari malformation. So with MRI, you need to exclude that. And single curves are less balanced than double curves. You can imagine that. Age, I already mentioned, the earlier the onset, the greater risk of progression. So now a little bit about maturity indicators that indicate actually the growth spurt and detect the most progression. First, bone and skeletal age. Risser sign is still the most popular and convenient because we see it on the X-ray of the spine. You can use the European version or US version, it doesn't matter. It matters that you always do the follow-up with the same version of the Risser sign. And lately, skeletal maturity is assessed according to hand and wrist, especially Sanders classification that is utilized lately. It is introduced in 2008. It is about ossification of the carpals, fingers, and the wrist. It has 8 stages. Stage 3 and 4 corresponds to puberty, and stage 8 corresponds to Risser 5, that is actually completion of growth. When we are comparing Sanders and Risser, you can see here that Risser's stage covers a large part of the puberty. So actually 2/3 of the puberty is related to Risser stage 0. This means that it has limited sensitivity and it can result in mistreatment. In research, it's 1 of 4 patients that are being mistreated and undertreated with Risser signs. So it's better to use the Sanders classification and utilize it during the growth and during puberty. There is also elbow ossification that we can use. And here, once more, you can see in the acceleration phase during puberty how progressive the scoliosis is. Here, this is the acceleration phase you have to take care of. Aggressive progression during growth with Risser 0, US Risser 1, and then there is reduced risk of progression with slowed progression. Here once more to emphasize how important it is to measure height and weight. And in non-ambulatory children, you can also measure arm span because divided by 2, it is very close to sitting height. There is also Tanner stages you can observe. And here Tanner stage 2 corresponds to the beginning of the puberty. So it is indicating peak height velocity or the acceleration phase where the girls grow over 6 centimeters annually and boys over 7 centimeters annually. And also gender and body type. I already mentioned that the girls are more affected. Why is that? Probably because the girls enter the growth spurt before postural mechanisms have maturated. So they enter the growth spurt in postural instability where they have reduced thoracic kyphosis, and this is why the scoliosis is more progressive in girls, unlike in boys that enter the growth spurt in postural stability. And the higher the Cobb angle rotation, of course, the higher is the risk of progression, especially for curves of 30 degrees. As you can see here at the beginning of puberty, risk of progression is over 90%, and in final stage, it's 30%. In adulthood, why is it important to keep the scoliosis below 30 degrees? Because these scoliosis doesn't show further progression, unlike scoliosis of 30, 50 and more degrees. It can progress, as you can see, during life, But whenever scoliosis is related to pain, independent from severity, scoliosis-specific physiotherapeutic treatment is indicated. Thank you for your attention. Now I'm open for a question if there are any.
Okay. Thank you, Dr. Samra Janik, for your valuable presentation. So we now we are open for discussion. I think we have a few questions in the chat room, Doctor. So I will read the question, ya, Doctor.
All right.
Okay. So the first question from Agus Tambunan. Can the age over 60 years still fix it from scoliosis?
Age 60.
Yeah, over 60.
Over 60.
60, yes.
Well, once the growth is complete, it is we cannot expect correction of scoliosis. Actually, we can expect stabilization of the deformity. So when you have an adult patient that has severe scoliosis, that experiences back pain, with specific physiotherapeutic exercises, you can ease the pain of this patient. You can influence a little bit its aesthetic. You can work on the alignment of the trunk and of the whole body. But it is, to my knowledge, it is not possible to reduce the scoliosis or to reduce the Cobb angle in those patients. You can do this only during the growth spurt, during puberty.
Okay, thank you, Dr. Samra Janik. So I will translate into Indonesia, ya, Dokter. Oke, seperti yang Dr. Samra Janik sampaikan bahwa untuk usia di atas 60 tahun itu sulit untuk kita ekspektasikan berkurangnya dari sudut skoliosisnya itu. Jadi secara garis besar yang bisa kita lakukan untuk pasien khususnya dewasa yang dari secara terminologis sudah masuk usia dewasa, kita mungkin dapat untuk mengurangi nyerinya yang pertama, terus adjust atau adjust dari alignment dari posturnya, tapi kita tidak dapat berharap banyak dari usia yang sudah dewasa. Karena tadi di paparan dari Dr. Samra bahwa menyebutkan bahwa ada namanya late onset di adolescent di usia 9 sampai 17 tahun. Jadi itu yang Dr. Samra sampaikan. Oke, Dr. Samra Janik, thank you. And the second question is, okay, wait a second. Okay, from Devi Siswani, how to distinguish diagnosis scoliosis in normal children or adolescents from children with other syndromes?
How to distinguish those scoliosis?
Yes.
Okay.
Yes.
First of all, like I mentioned at the beginning of the presentation, when we divide scoliosis, we divide it by cause. That's one of the classification of scoliosis. And then we talk about idiopathic scoliosis that occurs actually in healthy children. What does it mean, healthy children? That means that there are those children that function normally. They don't show any signs of any diseases, okay? So this is idiopathic one. But when we're talking about secondary scoliosis, there is always an underlying disease that leads to this scoliosis. For example, if we have a child with Down syndrome, now let's take that example, and you have a very low muscle tone in those children, you can expect those children to develop scoliosis. but you will not treat this scoliosis like you treat the idiopathic one. So it's a different type of scoliosis because you know that this scoliosis occurred as a consequence of the syndrome, as a consequence of low muscle tone in those children, okay? So this is what you need to know first to distinguish that in order to know which type of treatment you will apply to these children and also to know the prognosis, because the prognosis is also not the same. If you have a child, for example, with SMA, spinal muscle atrophy, that is, these are non-ambulatory children mostly. If you have scoliosis, you know that this is a consequence of the SMA. So when you do the brace treatment, you will not apply the same corrective treatment with corrective forces like you apply in a healthy child that has idiopathic scoliosis. You will apply a brace that will just make sure that this child can sit properly, that it has no pain, and that it has alignment during sitting. Okay, so this is first what needs to be distinguished. Is it idiopathic or secondary scoliosis? Because you treat it differently and you have different prognosis of these two types.
Okay, thank you, Dr. Samra Janik, for your explanation. So, right now I will translate into bahasa Indonesia. Jadi teman-teman semua, pertanyaan kedua itu bagaimana membedakan diagnosis skoliosis pada anak-anak normal ataupun remaja dengan anak yang mengalami sindrom lain. Jadi untuk membedakan diagnosis ini kita harus mencari tahu terlebih dahulu penyebabnya, apakah ini idiopatik ataukah ada underlying dari si skoliosisnya itu. Kalau dari idiopatik sendiri, seperti contohnya untuk anak-anak yang normal pada lahir lainnya, kita dapat memberikan treatment yang treatment untuk adjustment dari si posturnya itu sendiri. Sedangkan kalau untuk anak-anak yang ada secondary diagnosisnya itu, kita harus melihat terlebih dahulu penyebabnya seperti apa. Contohnya adalah Down syndrome, yang dimana Down syndrome itu dari tonus posturalnya itu salah satunya rendah. Jadi itu yang bisa untuk kita harus menyesuaikan dengan tumbuh kembangnya itu sendiri. Seperti itu secara garis besar yang disampaikan oleh Dr. Samra Janik. Thank you. For the question, we will only for three questions. So for the question, maybe the question will be explained in the next sessions. So for the last question is from Mr. Arif Visio. So I want to ask to Dr. Samra, what is the relationship between menarche and scoliosis, doctor? Thank you.
Okay. Well, menarche in girls is an important milestone for actually sexual development. And as you know, this development is closely related to the growth. And when the girl experiences menarche for the first time, it's an orientation point for us clinicians. That actually indicates that most of the growth is behind the girl. So the girl goes through the rapid growth and then it experiences menarche. It's RISR US, RISR 1 or RISR 2 at least. So when the girl experiences menarche, we can be quite sure, not always, but we can be quite sure that she went through the rapid growth and now goes to the stabilization phase. So she reached the peak height velocity and the rapid growth of the child is over, and then the deceleration phase starts. As you can remember this diagram I showed in the presentation, and when the deceleration phase starts, that means that the progression of scoliosis slows down. But we cannot use menarche exclusively to assess the growth potential. So it's just one of the parameters we use along with skeletal and bone age indicators. and tenor stages. I already mentioned in the presentation.
Okay, Dr. Samra, Janik, thank you for explanation. So maybe the relationship between manat is with hormone, isn't right?
Yes, but we look at it as a relationship with the growth, because as I told you in the presentation, progression is related to growth, and the more growth the child experiences in the short periods, you can be sure that this is a great risk of progression. So in this term, we're talking about menarche in relation to growth. So when the girl experiences menarche, the growth slows down. So the progression, the risk of progression also should slow down. But once more to emphasize, we cannot only look at the menarche and say, okay, this girl will not grow at the fast rates and so on. We also look at other indicators such as Risser sign or Sanders or Tanner stages. And altogether, these indicators can give us a picture about at which stage the girl is currently with its growth. Okay.
Oke, thank you Dr. Samra. So dari penjelasan dari Dr. Samra, menarche atau menstruasi ini bahwa ini ada hubungan dengan parameter dari pertumbuhan dari perempuan ini, bahwa di mana kita dapat memperkirakan fase di mana ada stabilisasi fase dan akselerasi fase. Jadi di situ sangat berperan penting terhadap treatment untuk dari pasien ini. Itu secara garis besar. Terima kasih. Thank you, Dr. Samra Janik, for this session, for the first session. I want to say thank you once again. So after this, we will continue into the second session. So for the second session, I will give it back to the host, Dina Widyaningsih. So, Dina Widyaningsih, time is yours.
Okay, thank you for Mr. Galuh and Dr. Samra for the next presentation. Mr. Nicola or Lumbonir.
Okay, first Nicola, then Lubomir, right?
Okay, Mr.
Thank
Nicola, right? Okay, Mr. Nicola, for the time, for the moderator, Mrs. Susan, please time. Susan.
You just let me know when I can share my screen.
Okay.
Okay, please.
Sudah?
Can I?
Okay, thank you for your time and thank you, Dr. Samra and Mr. Galuh that already see you now. So I want to introduce you. How is it? Okay, hello. First. Okay, sorry, my signal is a bit. Okay. So, panitia bisa share screen. So, Mr. Nicola is one of my best friend. He became our mentor and yang screen yang satu lagi kali ini. And last 2 so wait, sorry, can you change to another screen? It's too much information, so you need the shortcut. Okay, Mr. Nicola is one of the international scratch instructor for Europe, and very luckily, he come to our country to do the training for the first group last year in 2019 November. Yeah. Okay, so we have a great moment there. We learning and we do the training for 5 days. It's almost exhausting, but we having fun. Well, okay. So Mr. Nicola is Serbian. He is graduated from the medical school in Kruševac in 2005, and in 2011 he obtained the title of Professor of Physical Education, graduated of kinesiotherapy at the Faculty of Sports and Physical Education in Novi Sad. He graduated master degree at the same faculty in 2013. So it's very expert, yeah. From 2009 until 2010, Nicola was engaged as a demonstrator in the subject of kinesiotherapy and professional practice of kinesiotherapy at the Faculty of Sports and Physical Education. During this period, he gained work experience while working on improving motor skills in preschool children in sports school. So Mr. Nicola is already good in the teenage and all the kids. The aim of this approach was to establish adequate growth and development through the application of corrective exercise. After 1 year of work at the faculty as a teaching assistant in the subject kinesiotherapy in the period 2011 and 12, Nicola went to as clinic in Germany, specializing in the scroll three-dimensional method for the correction of scoliosis and kyphosis. Upon returning from Germany, he began to professionally apply the knowledge of the scratch method to working with people with scoliosis and or kyphosis. From 2014 until 2015, he was involved in a team of researchers of the IPA. Spine Lab. IPA is a Spine Lab international project entitled of Improving Postural and Spinal Status Assessment, which was successfully conducted by the Faculty of Sport and Physical Education in Novi Sad in cooperation with the Faculty of Sports and Physical Education Sarajevo. Upon completion of the project, he became a visiting lecturer at the Faculty of Kinesiology in Split, Croatia on the subject kinesiotherapy. Having become a regional scratch instructor on behalf of the German Spine Concept, Soberheim Institute and Asclepios Clinic in 2017, he became entitled to conduct scratch education. So far, he has conducted education in Serbia, Croatia, Bosnia, Herzegovina, Bulgaria, Netherlands, so many, Greece, Indonesia, Romania, and Ukraine. So Indonesia, one of the Asian country that he already visiting. Thank you for that. So for your time, this is your time to explain about the multidisciplinary in physical therapy. Thank you.
Thank you so much, Suzanne. It's a big pleasure to be part of this event. Actually, I'm happy to see a lot of familiar faces because I already visited Indonesia, and I hope that I will come because of pandemic situation. We a little bit stopped with the second part and hope we will see each other personally again soon. And also the idea, and that will be good aim to establish the multidisciplinary team in Indonesia, also as we are trying to establish multidisciplinary team here in Europe and Serbia with Samra and Ljuba and myself. I will share my presentation now. Everyone can see?
I can see
Yes.
that.
Yeah?
Yep.
Just,
Yes, we
okay,
can.
great. Yeah, as the topic here is the physical therapy in with scoliosis patients, I will give you some more information about therapy plan, about the treatment, and what we can expect. I also want to say many thanks and thank to Dr. Samra for very nice presentation. Actually, the Schrott starts from Germany, and actually Schrott, let's say, born in Germany with Katharina Schrott. Katharina Schrott was the founder of the Schrott. Sorry, the Katharina Schrott was is the founder of Schrott method. She was born in Dresden in 1894. And she was born in east part of Germany, in Meissen. But during the complication with Second World War, she moved with her family to west part of Germany, in Bad Zobenheim. Actually, she had mild scoliosis, and that is how she started with the method, because she started to discover her body. And also, she was a teacher of Swedish gymnastics. Then she took a lot of elements from Swedish gymnastics to improve her new method, which now is called the Schrott method. When we talk about further development of the Schrott method, Christa Lena Schrott is the daughter of Katharina Schrott, and she continued to develop the Schrott method in Germany. After Christa, they had the help from Dr. Hans Rudolf Isst, who is the son of Katharina. Until 2008, he was in Asclepios clinic. After that, the team of physical therapists Udo Rovinisch and Axel Hennes continued to develop the Schrott method in Germany and worldwide. On this picture, you can see the old clinic. That is the old Schrott clinic. It was the more buildings, and in one building was the kitchen, in another building was the accommodation, and in third building was the hall for treatment. And after that is why they sold their method and they to Asclepios company, and Asclepios company made one more big and modern clinic in Bad Zobenheim, in a very nice area in Bad Zobenheim, and they have now everything in one place. In this clinic, we finished the Schrott method. In Asclepios clinic, Asclepios clinic is on two locations. One is in Bad Salzungen and other is in Bad Zobenheim. In every moment there are 180 patients and from 7 to 70 years old, but mostly of them are adolescent from 12 to 16 years old. Actually, they have patients from Germany and from abroad. That is why for German patients, everything is covered. The treatment is covered by German insurance. For patients from abroad, they have to cover expenses by themselves. The treatment in Asclepios include from 3 to 5 weeks intensive treatment. That is inpatient rehabilitation. Inpatient rehabilitation means that they are 3 weeks, 4 weeks in the clinic, and they are doing exercise 6 hours per day. The founder of ISST, which means International Schrott Education and International Schrott Treatment, is our mentor, Axel Hennes, senior Schrott instructor. Till 2008, everyone can finish the Schrott method, but just in Germany, in German language. That is why he started with international education and to start to spread the Schrott method worldwide, and also to expand this method in English language. From 2015, he started to establish his international and regional instructor who will give the education out of the Germany and in other countries in Europe and worldwide. The idea, as we will trying to present you, is the multidisciplinary team. But what does it mean, multidisciplinary team? The multidisciplinary team includes a doctor, as we have Dr. Samra, orthotist, as you will have a chance to listen after that, the Ljubomir Matic, and me, like that's Schrott therapist. What is the important with this multidisciplinary team? All of these three persons has to work together, and they have to think in the same way. They have to help to each other. They have to have communication. Why? Because of how to find the best way in current moment to help to patient. That is why it's very important to have good team who will work together, who will communicate between each other, because we are here because of the patients. The conservative treatment, scoliosis treatment, include the physical therapy, the exercises, manual technique, and also the brace treatment and exercise in brace. We can do exercises in brace if the brace is exactly compatible with our exercise. That is why we are using the Zobenheim 3D brace, is the 3D dynamic brace, but something more about that will tell you Ljubomir Matic. Also, what is the very important is important to explain to patients how to help themselves. We have to do everything to try to avoid the surgery. That is why first we have to give exactly the good information to parents, and also we need to think how to make the good treatment to divide, because the treatment is includes exercise, manual techniques, and also active daily living. We need to do everything to make the clinical correction, to have better clinical picture, to have after that spinal radiological correction, but also what is very important, to change the patient's routine. That is the active daily living. With active daily living, we have to have different routine that patients had before, because we need to avoid asymmetrical loading, and we have to explain to patients how to keep their posture during the day. Also, it's important to improving the compliance with brace treatment. When we talk about Schrott exercise, it's important to understand that we have 3D stabilization, three-dimensional stabilization, specific mobilization techniques, which include active, passive, and also assistive techniques. Then type-specific basic corrections. We have specific corrections for major thoracic curve, specific correction for major lumbar curve. Also, we need to try to correct the patient in all of three planes. And also, that is why is important this 3D correction: sagittal profile, in frontal, and transverse plane, sorry. Then we have also home exercise program, which is established with very easy exercise and with exercises that we are sure that patient can do that in good way. Stage in learning process, we have a cognitive phase, associative phase, and autonomous phase, which means that we have first to give idea to our patients, to explain them how to do that. Then after that, to do together, to start to teach them. And after that, they need to have automatical movement and automatical changes, how to correct themselves and how to do the exercise. The very important treatment when we are doing the examination, and why is that important? Is that important for treatment? Because when we are checking the flexibility with patients, if we have a structural curve, we need to have with manual techniques. We need to start with manual techniques. Why is that important? Because we need to increase the flexibility. We need to explain and to teach our patients as fast as possible to learn the movement. And after that, when our patients is more flexible, we can start with exercises. Then if we are going on other side, if we have functional patients, we need first to make some postural training, conscious posture, basic muscle tension, to explain what is the relaxed posture and to explain how they have to play during the day. Then after that, we can start with exercise. As you see, Schrott is not just exercise. Schrott is one complex process. And that is why the physical therapists need to have exactly, it's a good education if they want to start with Schrott, to do the Schrott with their patients. Then if you see the pictures, you can see that we have different positions when we talk about exercises. Then we have corrective breathing, which is very important. We have to change the volume during the treatment, and because we have different geometrical position of the patient and of the patient's spine. Then we have specific mobilization that we already mentioned. And after that, we have 3D exercises, which means you can see that that is the long process. And also we have home exercise program, as I mentioned before, that is the easy exercise, simple exercise, and we have to also do this exercise our patients have to do this exercise in good way. We dividing when we are talking about classification, we have to classify the patients, and we are dividing the patients in 2 different groups. That is the T-type with major thoracic curve and L-type with major lumbar curve. That is very important because we have basic corrections, and with T-type, we have the basic correction side shift towards the L side. To be clear, what is the L side? L side is the side where the lumbar curve is. And also we have derotation of the ventral prominence, derotation of the ribs to have 3D correction. With side shift, we have correction in frontal plane. With derotation of the ventral prominence, we have derotation, we have correction in transverse and sagittal plane. For L-type, we have pelvic tilt, we call that 5th pelvic correction, that with 5th pelvic correction, we are correcting the pelvis in frontal plane. Then we have lumbar derotation, which is the 4th correction. We have correction with 4th pelvic correction in sagittal and transverse plane. And we have lordization, which means to establish the normal lordosis with some specific mobilization techniques. We call that basic tension and moving the ribs. As you can see on the pictures, that is the basic corrections. T-type, we have side shift. The T-type, we have derotation of the ventral prominence. L-type, 5th pelvic correction, 4th pelvic correction, derotation, and relordization, as I mentioned, moving the ribs. Then, when we talk about pelvic correction, I always say that is the increasing, the lifting the hip on L side, and immediately we have lower curve, we have less curve, but also in thoracic curve, we have some correction because always patients are looking for the balance. They don't change, they don't go to the other side. They are trying to stay in the balance. And when we lift this hip, immediately we have elongation of this patient and correction in both curves, but mainly correction is in lumbar curve. When we talk about pelvic correction, we have 5 types of the pelvic correction. First is to adjusting the feet, the knee and leg axis. Then after that, to adjust the lumbar sacral junction, actually the lumbar lumbosacral lordosis. Then number 3, third pelvic correction means that we have to correct the pelvis in neutral position in frontal plane. If we have hip which is moved to one direction out of the balance, we have to put the pelvis in neutral position in frontal plane. Then we have derotation and also the correction of the pelvis in frontal plane, but to elevate, to correct the iliac crest to be in same level. When we talk about 3D breathing, you can see what does it mean 3D breathing, that during the inhalation, patient has to open the weak side. Actually, weak side is the concave thoracic part. As you can see on the picture, the difference, if patients are not aware how to do that, we have to teach them step by step, and at the end to have this result during the inhalation and during the breathing. Also, we have specific mobilization, as I already mentioned, passive technique, then active technique. Passive technique therapist is doing, active technique patients are doing, and therapist is giving just resistance. When we talk about specific exercises, especially I will mention now muscle cylinder. Muscle cylinder, that is the name of exercise, and we are doing this exercise especially for major lumbar curve. What is the aim of this exercise is isometric activation quadratus lumborum on concave lumbar part, concave lumbar area, and we have to first adjust the lumbar curve, then after that to have activation of the quadratus lumborum, to have isometric activation of quadratus lumborum. Then when we have a major thoracic curve, we have similar position, but it's totally different action, because we have let's say, as I mentioned, similar position, but now with this stick, we are helping to patients to open weak side, concave thoracic. In previous picture, we had open lumbar concave side. Now our aim is to open thoracic concave side. That is why it's very important is the major lumbar or major thoracic curve. Additionally, with this position, we have 3-dimensional breathing. Pelvis has to be neutral for thoracic, for patients with major thoracic, pelvis has to be in neutral position. When we talk about active daily living, the crucial moment to explain to children how to wear the bag, how to take something from table, or doesn't matter which hand, which arm can to lift. We are always trying to lift the hand on L side when we have major thoracic curve, and in this situation we are trying to open weak side, that is the concave thoracic side. It's not possible to do this because in this situation we are increasing the curve. That is why always we have to do that in proper way. Then also the picture, how we can teach the patient how to sit, how to learn, how to study. We always have to find the best position for our patients. That is additionally, that's very important to have good position, and also between that to have good exercise treatment. Home exercise program has the principles that we have some goals, how to planning the exercise, and also some reevaluation and measurements are important. Then home exercise program have practical and functional case-specific exercises, easy and safe version, which is crucial part to have easy exercise that patient can do in good way. And also this exercise, it's recommended to do 30 minutes 5 times per week. But if we have patients with a big risk of progression, it's always recommended to do every day. Of course, implementing the brace is already prescribed, and it's very important to have a brace in this situation. Goal is to prevent the progression, to stabilize, and to increase motivation to patients to have motivation to do the exercise and to wear the brace. This job is not easy, and especially for patient and for parents. And if we have a situation that psychologically patients are not ready to do exercise every day and to wear the brace, that can be also the big problem. When we talk about a home program, you can see it's not necessary to have some specific equipment. Everything can be simple, easy, but everything according to the good position and according to the curve, which type of the curve. Here is also a position for exercise. You can see we can use just chair, which everyone at home has, and also that some guidelines to our patients, we can send them some to take a picture with them, to explain them where is the 3D breathing, in which position pelvis has to be, in which position hands has to be, what does it mean, elongation. Also, here is some results with short treatment in combination with brace treatment. That is also very important, to have good brace, to have good treatment together. You can see how looked like the curve, but you can see also how she looked like in position during the exercise. It's totally different clinical picture during the exercise. Also, you can see on the next slide, next picture, you can see how is the big curves, very severe curve, but during the exercise, she looks perfect. Actually, that is just during the exercise. It's not final correction, of course, but it's very important to do exercise and to make good position with patients, to see immediately some clinical results, or to see that patients are in structural limit. You can see it's very severe curve. Actually, it's recommended for surgery, but definitely sometimes parents reduce that and trying to do their best to try to avoid the surgery, but it's recommended these patients for surgery. Also, when we talk about the goals for short and brace, it's I will just say some words, but because I will give the words after that to my colleague Yuba to talk something more about that. But it's definitely improvement of compliance, brace wearing, wearing hours to increase and improve the motivation of the patients, improvement the end results, to conservative therapy, and also that is the very important to understand how to do the good exercise in brace. That's also one of the crucial part. And also it's not recommended to do the exercise all the time in brace, because the patient has to wear the brace during the day. After that, he has to do the exercise. But sometimes we can combine exercise in brace. You can see how we teach them to do the exercise in brace. It's very simple. We can use some sponge to put in their breathing zones, to try from them to open these breathing zones, to open this weak side, and to change some position, because good brace will not give chance to patients to go in wrong direction. That is the picture with inpatient rehabilitation. That is the short camp, and also the how the treatment looked like in Germany. This picture is from Germany. These pictures are from Schrott camp. Also, this picture is from Germany, this picture is from Schrott camp, which means we are trying to implement Schrott camp that is the intensive patient treatment, 7 days, 4 hours and a half, and almost the same therapy plan as in Asclepius, which means that we are trying to do this international inpatient rehabilitation, to do these short camps in other countries also for children who need this intensive treatment. This is the some results, and you can see, don't be confused because here is the thoracic right curve, but just PA projection. It's the picture how patients look like, and now that is the result after 6 months from 51 degrees to 41. That's 10 degrees in 6 months. Also, that is the other result. The patient, you can see how patients look like. That all of these results are in combination with brace, but this result, this X-ray is out of the brace. Also, you can see here, this is the very important to explain. This girl is 9 years old, and it's very important that we correct her curve before she started to growing fast, because this situation can be very difficult for her after, during the growing spurt, during the fast growing, because definitely can progress in this age. Now she's in more stable situation, and now we are ready for her growing spurt. That is also one very good result. You can see how patients look like first time when came to us, and after that, after 1 year and a half, you can see totally different picture, totally different picture of the child, and you can see from 52 degrees to 26, it's very nice correction. Also, kyphosis, you can see how severe kyphosis we correct. It's also the child has 15, she's 15 years old, and we had a good correction with this child, but a lot of things depends on the children. That is the very important, to have children who will listen, who will work hardly. That is the very important part. Also, some pictures without X-ray, just clinical picture. That is the short treatment result in 6-7 days. How patients look like clinically. We didn't have control X-ray because it's short period, but definitely we can change. We can do our best to change patient position for this short period, but do not expect to have radiological result. This picture is the most important for me, because you can see on one picture 3 specialists who are working just for 1 patient. That is the win-win situation. That is the best option for patient. This is what we are trying to make, what we are trying to increase. And as I told you, I hope that we will give our best also to establish the multidisciplinary team in your country. Thank you so much for your kind attention, and I hope that this presentation give you a lot of new information, or yeah, that you are happy with this, with my speech. Thank you so much.
Okay, thank you for, oh, I'm upside down. Okay, sorry. Okay, thank you for the explanation, the slide, Nicola. And I hope some of the visual already understand, even in the English. Sorry, we cannot translate directly because remember about the time. We don't have so much longer time. So now we open for the question. So first question is about, actually Nicola is already explained, but we still have to give you a question. So what about in the case of structural scoliosis in 9 years old? What the main thing that we have as a physio to remember how to not doing wrong when we do the exercise for them to not make it worse the curve. As you say that in the first slide, that the at the 9 years old is very crucial moment that as a physio to being part of their progression in the curve.
Actually, when we have this early onset scoliosis, it's very important to implement immediately the good treatment and also the good brace, because this child has very big potential to progress, to increase the curve. That is why I cannot exactly give you the answer what we have to do to not make wrong the therapy, because that is why I mentioned that physical therapists have to be very well educated to understand what is the good for this child and to make the good therapy plan. But definitely if we have structural curve, let's say, always is the question, what does it mean? Structural curve is the less flexible and severe, and that is why we can say that if we have the curve with the child 9 years old, we have immediately start with treatment. Sometimes we have very severe curve in that age, which is regulated for surgery. But if it's the child for conservative treatment, we have to increase flexibility. Actually, the children in that time are flexible, but the question is that if is the curve structural, that is now the different thing, because if the curve is the structural, we have to first try to increase the flexibility, then to implement good exercises.
Okay, thank you for the explanation. I try to translate in bahasa Indonesia. So, jadi pada kasus struktural scoliosis umur 9 tahun, sebagai fisioterapi kita harus istilahnya important thing to remember, hal yang penting untuk kita selalu ingat, kita harus kasih good treatment dan good brace choosing. Nah, karena pada usia 9 tahun ini mereka terbilang fleksibel, jadi kita bisa memberikan treatment lebih ke flexibility exercise. Tapi ya tidak, semuanya tergantung dengan kliennya sendiri. Kalau misalnya kliennya memang susah berkomunikasi, seperti yang Nicola bilang, banyak anak-anak yang nggak mau berkomunikasi baik dengan kita sebagai physio. At the end, karena dia sudah severe kurvanya, optionnya adalah surgery. Dan kita berharap sih kalau memang anaknya bisa bekerja sama dengan kita lebih baik, kita bisa lebih memberikan latihan konservatif. Kira-kira seperti itu. Okay, I'm going to read about the next question. The question comes from us about scoliosis in method, what is muscle weak? So that is the question in geriatric elderly. What should we do as a physio to help them with the curve or with the problems?
Sorry, its connection wasn't so good. I didn't hear you well. Could you repeat, please?
Okay. Okay. You can also read from the chat. Okay, so the question about scoliosis in elderly, we are know that many geriatric with deviation lumbar or thoracal can deviation in lumbar and thoracal. Can scratch method working with geriatric when geriatric problems is less flexible and muscle weakness and other problems?
Can stroke method working when?
In geriatric
for adult patients.
Yes, yes. Adult
for
person
adult
with
patients.
Less flexible, weak muscle, and other problems.
Definitely yes. Actually, Schroth method is the specific physical therapeutic treatment for scoliosis, and mostly we are doing for idiopathic scoliosis patients. Also, is it possible to work with adult patient who has less flexibility? Definitely they have less flexibility because they are structural, but also the aim is the different. When we are doing with scoliosis patients in adolescent period, we are looking how we are trying to correct the posture, to correct the spine. When we are working with adult patients, they usually have a problem with pain, and we have to try to reduce this pain. That is why it's different aim. And also for adult patient, we are trying to stabilize the body, the spine, do not have pain in future, and to have good quality of life. Because for these patients, for adult patients, quality of life is the very important.
Okay, I try to translate. So, Scratch method untuk geriatri problem, main fokus adalah kita harus mengkoreksi postur dengan tujuan adalah mengurangi nyeri. Dan another important thing adalah to stabilize the spine, supaya adult kan memang dalam masa-masa weakness-nya itu, or muscle weakness dan flexibility itu memang paling banyak menimbulkan nyeri ya. Jadi dengan menstabilize the spine, kita bisa lebih merealignmentkan posturnya, dan sudah pasti secara anatomical dan secara teorikal ya. Dengan stabilize spine, pain-nya itu pasti akan reduce. Seperti itu. Okay, karena kita hanya 3 questions, so we only have 3 questions, but so many questions coming. I have to choose the quality question. Wait, yeah. Okay. So there's some participant asking about the brace. I will keep that question. I will give it to Galuh when the Mr. Matic doing this session, after doing the session. So I'm gonna choose the question. Okay, is the Scratch method apply for individual patient is different, or if each individual patient have a different Scratch method, or only one Scratch method apply?
Actually, short method is one method, but every patient has can have different exercise according to their curves and according to degrees, according to where curve starts, where is finished, which means the treatment is the individual approach.
Oke, jadi translate ya. Jadi Scratch method hanya punya satu teknik, tapi untuk setiap pasien individual itu tergantung kurvanya. Cara kita memberikan latihan dengan metode Scratch. Jadi memang setiap pasien pasti berbeda kurva, pasti berbeda metode latihan. Tapi dengan satu prinsipal, itu adalah Scratch method. So we already have later the question about the break. I will give it to Nicola for your time and for your good explanation. I hope all the official and doctors and also OP can understand our portion is in approach of multidisciplinary in idiopathic scoliosis. Thank you for your time again, and do not leave the chat, the Zoom yet, because we have a stage.
Thank you, Suzanne.
Okay. Thank you. Yes.
Okay.
Yes.
Okay. Thank you.
Yes.
Thank you so much. Thank you so much.
Yes,
I just wanted to invite them on if it's on meeting SCOSIM that you know. Maybe I can share just one slide to show them what will be next.
Yeah. Please.
Okay.
Yeah.
Just one slide. Thank you for. the next week in Serbia will be the big event, and it's also possible to have online registration. You can send the email to this registration. Is the hybrid event. It's more people from, also a lot of people from Germany. You can see Axel Hennes here, and physical therapists from Asclepios and doctors from Asclepios. You're welcome to join to our meeting virtually. If you want, you can make registration by this email. Yeah, thank you so much for giving me the chance to share this.
Yes. Thank you. Yeah, I will be joined also, and from here, some of the group official, they will come to my place, and then we can watch together. So some official also can, yeah. So because we are in Jakarta, maybe in Medan or other province, can join the hybrid symposium. It's very nice. And thank you for sharing us. I will give them the information. You can send it email to me, and I will pass to them. Okay.
Thank you.
We welcome
Thank
again.
you.
Yes. Thank you. We welcome again Mr. Galu and Mr. Matic for the next session.
Yes, thank you, Nicola and Kasusan for the second session. Thank you very much also for Nicola for a very nice presentation. Okay, for the next session, or will be the last session in the third session, we will invite the Mr. Jubomir Matic. Mr. Jubomir Matic, are you with us? Hello. Oh yes, thank you. Okay. Before we start the third session or the last session, I would like to read our CV speakers. So the full name is Jubomir Matic, and date of birth is 19 March in 1983. He also a member of Commission on Practical Exam for LLO Cat 2 students, and he is a lecturer on second Banjaluka ISPO symposium, and also main educator on practical workshop Turkey in LLO Advanced scope in 2019. Mr. Jubomir Matic finished his Bachelor of Prosthetic and Orthotic in Mahidol University in 2019, and also got the ISPO Cat2 professional from Don Bosco University in San Salvador, in Munich, Germany. So without further ado, please welcome Mr. Jubomir Matic. Mr. Jubomir Matic, time is yours. Thank you. You can share your presentation, Mr. Jubomir Matic. Sorry, you still mute. Yes.
Susan, could you try to unmute Lubomir? He says that it's locked.
Okay. Yeah,
it's
yeah.
locked. Okay, perfect. Now it's good. But we don't hear you. Don't hear you.
Hello, Mr. Jubo Mirmetik.
Jubo. Ne čujemo te. Izvuci slušalice.
I cannot hear you.
I'm trying to help him. Just a second.
Okay, Nicola. Thank you.
Maybe he has to leave first and then join again.
Okay. Suzanne, maybe during the Luba is coming, maybe we can give some more answers, Samra and me, on some questions. Oh, sorry, Luba is
Yeah,
coming.
already. Okay, maybe I can open one question, yeah. A question for Nicola also can answer, or Dr. Samra from Mr. Johannes Purwanto. Are there any differences principle of treatment of idiopathic scoliosis and secondary scoliosis from neurological condition in children and adolescents? Nicola can answer, or Dr. Samra. So about neurological treatment for a neurological.
Yes, I think we had a similar question that I already answered. The question was about idiopathic scoliosis versus secondary scoliosis. So when we talk about
Yes.
secondary, this kind of scoliosis is also present in neurological patients. We do treat this scoliosis not with specific exercises, especially if the child isn't able to follow the program due to due to impaired mental capacity of the patient, but also due to different neurological deficits that the patient has. But when it comes to brace treatment, we also make braces for those patients. But we have the difference between ambulatory and non-ambulatory children. So if you have a child with neurological deficit that who walks, so who is immobile, then putting a brace on this patient can be quite a challenge, because this child or those patients mostly walk with the compensation of the trunk. So when you put the brace on this child, you can inhibit their mobility. So you always have to look more closely on it. If it's a very large scoliosis, then you can do some brace modification. But also Ljuba can talk about it when it comes time. He can give his experiences in the bracing of those children. But in a non-ambulatory children, so when you have a child in a wheelchair that sits and develops scoliosis, then you don't do the 3D brace like you do in children with idiopathic scoliosis. So you don't apply these corrective forces like you do in children with idiopathic scoliosis, but you do the brace that will only stabilize the trunk. So to make able to do the alignment of the trunk in this patient, to stabilize it, and to reduce pain in this child. So if Nicola has some additional information about it, but when it comes to physical treatment, it's very, very reduced in those children when it comes to PSSE exercises.
Okay, thank you, Dr. Samraya, a very clear explanation. Yeah, I think it's very difficult to put the brace on that neurological patient because we remember about the symptoms they have, yeah. So that's why we still wondering what is the best time to give them the brace time on the wheel with the patient with the wheelchair. Is it when they were resting? Because we are remember that in the resting time the spine can grow better. The spine can grow better. So what do you suggest? What do you suggest?
Actually, in the non-ambulatory children, we always say to the parents that they put the brace during sitting and also during sleeping. So it's better for the patient to have the brace as much as possible. So we're talking about non-ambulatory children. If we have a child who walks and it has severe scoliosis that needs to be braced, then we recommend for this child to also wear the brace during the night and during sitting, for example, in school, to have the alignment of the trunk, but not while walking because it can inhibit the walking process in this patient.
Okay, thank you, Dr. Samba.
Luba is here.
So I
Thank
think
you.
finally I'm here.
Thank God.
Sorry for I changed the
Welcome.
headphones and something with the adjustments in the system. So I wanted to say welcome to our multidisciplinary webinar. And I will
Mr.
start.
Matic, Mr.
Yeah.
Matic, do you want us to introduce you by Galu?
No,
About your city, so we all know.
I heard everything. So there was just a mistake.
Ah,
The
yes.
Mahidol University was not in 2019, it was in 2016, because 2019 difficult to travel.
Sorry. Yeah.
Yeah, it's 16.
So I will share my screen. So do you see my screen?
Yes.
Okay.
Good.
Yes.
So I will talk about a little bit about the current principles of the spine correction according to the Zobenheim brace. So like you already mentioned, I'm the CPO, which means the Certified Prosthetist and Orthotist Category 1. Category 1 means that I'm instructor for the prosthetics and orthotics. So like the previous speakers and Samra says, this is the starting point, and the scoliosis itself, it's a lateral deviation of the spine, which is measured more than 10 degrees on the radiographic analysis. So that's important to know. That's the old definition, and the new definition is that the SOSOT added with rotation of the vertebrae. Why I'm putting the accent here? In the past, maybe 10 or 15 years behind, we didn't pay attention a lot or never ever on the rotation of the spine, which Nicola also said, the transversal plane. So the scoliosis, it's a lateral deviation of the spine, but also we need to speak about the rotation, sagittal profile, and the transversal plane. So also something which is mentioned before, in the physical examinations, between the let's say approximately 10 cases which is suspicious, from that 10% you can get from 1 to 4 of confirmed scoliosis. And the ratio between the females and the males are 5 to 6 according to one boy. So sagittal plane, like I said before, thoracic area, which is from 25 to 45 degrees. It's depending from the people and from the case. And in the thoracolumbar junction between the L1 and the TH12, we have sometimes minus 10 degrees to plus 10 degrees, which is also in the normal areas. And for the lumbar spine, it's becoming from 25 degrees up to the 65 degrees. That's a little bit too much, but sometimes it's also normal. So just the case on the right side, which is showing everything is straight. So we don't have the lumbar lordosis, we don't have the thoracolumbar junction angle, and no thoracal kyphosis. Everything is straight. 75 of all scoliosis, it's coming from idiopathic, meaning which means that we don't know the reason why it's happening exactly. And 75% of scoliosis, it's like that. The rest of the scoliosis becoming coming from the neuromuscular, congenital, metabolic, caused by tumor or trauma or others. And that's the classification for the structural scoliosis. And when we speak about the non-structural scoliosis, we have the postural and the leg length discrepancy, let's say. So when you have the patient and do the treatment for the brace, we always pay attention on the leg length discrepancy, because sometimes you have the leg length discrepancy 1 centimeter or more. But when you do the treatment with the brace, you should measure once again the leg length discrepancy with the brace, because we also counting on the correction, and the correction can create the difference between the previous measurements in the leg length discrepancy and after our treatment. This is the incidence of the curve progression, and you can see here below the age of 10, there is a 100% that the case will progress. So that scoliosis will progress if we have the starting point more than 20 degrees according to the Cobb angle. And later in the age of between the 11 and 12, 13, 14, it's becoming less and less, but you can see the first case, it's 100% that it will progress if the patient have more than 20 degrees. Why this? Also in my country, the old principle is to start when the patient have more than 30 degrees with the scoliosis, with the brace. We do the therapy, we do the shot, we have everything, but we are a little bit late with starting with the brace. So 30 degrees, it's a little bit too late. Not a little bit, it's too late. So etiology, like we said, idiopathics means that we do not have the single clear etiology. Can be connected with the genetic, like the Samra said, the family prevalences, mother to daughter, sisters, hormonal changes, connective tissues, or proprioceptive dysfunction, or combination between those things. This is the Nash and Moe vertebral rotation. So why we have here this? When we treat the like a case on the left side is, so it's a lateral deviation of the spine, but you can see Sometimes I'm calling this area, this holes like eyes. So you can see in the lumbar area 2 eyes, and in the thoracal area just one. It's easiest way to identify the rotation of the spine. So when you find the pedicles on the both sides, you have the technique to measure how much rotation have the patient, and that's also important in the transversal plane. You cannot correct the spine just by the pressing the spine on the lateral side. You should have in the mind always transversal plane, which means also the rotation. Research sign and the growing phases, like the summer said, we also paying attention in the separate treatment or multidisciplinary team. We are speaking in the same language, the first menage, the research sign, and all key points which is connected to the our successful treatment. When you have the X-ray without the iliac crest, it's a difficult sometimes to have the proper plan of the treatment. So you must have everything. Samra had in the Banja Luka, in their hospital, the great X-rays, because they are including everything which is needed for the best treatment. So iliac crest for the research sign, they know about the skeletal maturity. They speak with the patient and with the parents about the first menage to know the peak ground velocity, how it will go. And when you have everything which is in that part of the treatment, we can be successful. Someone had a question between the type of the braces, and we will speak about that later. And this is a little bit history in our region. We don't use the Milwaukee more. I have a really bunch of pictures of the type of the braces, but I just pointed 3 most important, because there is a difference between the corrections. Milwaukee is doing the lateral correction of the spine, but he have the ring which is creating the extension of the spine. If we come back to the sagittal profile and we speak about the lumbar lordosis, thoracal kyphosis, this brace must become the history, because it's decreasing the physiological sagittal profile, which is important to have in the normal sagittal profile when we do the lateral pressure for the lateral deviation of the spine. So this is just what the Milwaukee have. The ring in the neck area, the 2 posterior metal bars on the back, lateral bending pads for pressure, and the pelvis girdle, which is holding the pelvis in a good position. And it's not aesthetic to be in this time wear it. I had the case maybe 1 month before. The girl came with this, and I didn't accept, because we cannot do it anything with the Milwaukee type of brace. So this is also the type of the Boston brace. We also do not do the Boston brace more, because it's too much symmetric brace, and for the short therapy we need the expansion space for the breathing, respiration guidance. And with the Boston brace, it's not okay if you treat the patient with the shock therapy. You saw what Nicola shows with the positions, with the special things to put between the curves on the sitting point and so on, the breathing function, and then you put the child in the symmetric brace. Doesn't have any sense, because you need to continue with the asymmetric brace, which is in the synergy with the short therapy. It's simple, it's easy. You're doing the same thing, but you need to be with the asymmetric brace, which is in the synergy with the short therapy. So dorsal fastened, it's difficult for the patient to fasten the belts on the back. That's one thing. And the other thing, which is good for the Boston brace, there is a many studies which is available for the Boston brace. But I will put in the focus mainly thing, because I'm 14 years in the practice, and I also started in some time with the Boston brace, and I know the difference between the braces, because sometimes I put the patient to said the first words when I put the brace. I'm just asking, what do you feeling, the difference between the braces? When the child who already have the experience with the physical short therapy start to breathe, there is no other option instead of the breathing in the expansion spaces. So the passive brace, it's becoming active brace, which is needed. Every brace, it's 50% passive brace. The asymmetric 3D brace needs 15% more, and it's asking from the patient to start with the short therapy in the brace, to implement the short therapy in the brace. It's a difficult, but the only way. So just the picture of one, also the brace from Italy, which I also don't like, because can give on the X-ray the good results. But when you don't have the expansion space for the breathing function, when the child take off the brace after some time, after a couple of months, it's obviously what will happen. So the spine will collapse. This is the story, which is very old, from 1980s, and it's becoming from the man in the middle, which is Mr. Chenot, and it's becoming from the France. Idea is the same. The pressure zones in the opposite sides, expansion zones. Controlling points for what? For the derotation in the brace. So idea, it's old, but it's still working well. This is very important for me. It's also from the Asclepios Katerina Schott Clinic in the Bad Zobenheim. Their results for the braces, and you can see here what is important for them: to start with the brace earlier. If you start with the brace when the patient have more than 40 degrees, and the patient have between the 7 and 9 years old, the 35% you will have the chance, if you have the perfect brace, perfect child who knows how to do the short therapy, you will have 35% to have the correction. Not exactly, I'm not speaking exactly how much, but to have the positive effect. Let's say to hold the spine, or have 5% of the correction. So for those 5% of the correction, you have just 35% chance to have the correction. When you come back here and see, if you start with the brace when the patient have less than 25 degrees, 95% there is a chance that child will have the correction. It's easy. We are starting with the brace too late. We're waiting that the scoliosis have 30 degrees. I'm speaking, let's say, isolated in my country, it's like that. You will find the connections if something is happening also in your country. So start earlier. In the Germany, which is a little bit unusual, everything is twisted, and on the first place they have the static point, which is important. A static point for the girl, let's say, when they stay in the front of the mirror, they don't see the cob angles, they don't see the curve. They see in the first place the bad posture and the bad trunk, asymmetric trunk. So for the in Germany, it's important on the first place to have the static correction. Nicola shows also, and he said, you see the examples and you see the results. Those are the clinical signs. And sometimes you can see the results, very positive results. But the radiological findings, it's a different. The patient still have the curve, but also the static point, it's important. The quality of life, disability, back pain, progression, breathing function, and on the place 8, it's a Cobb degree. Maybe it's unusual for someone, but yeah, on the 8th place, it's a Cobb degrees. Samra had also the similar slide, which is the practical approach scheme for the wearing of the brace. And you have here everything. Cob angle, the observation, partial time brace, full time brace in the period of the scoliosis it's presenting, juvenile, infantile, and adolescent scoliosis, which is also nice to have and try to have the guidance from this practical approach scheme. Principle didn't change too much in the last 20 years because we need the pressure from the sides to correct the lateral deviation. That's one thing. But the change is coming. Sorry. So change is coming in the pair of forces system for the axial derotation. So you can see here, for example, the lumbar pad. Those lumbar pads have also from the dorsal side pressure because we need to have the rotation of the spine. The breathing function. So the first fitting, we are pressing the sternum and we are stopping the left side for the thoracal area, and the patient have on the right thoracal anterior side space for breathing. So then we speak about the respiration guidance and the rotation in the, let's say, thoracal area. So also the first fitting, the patient doesn't know anything about the short 3D exercise, but he doesn't have the opportunity to breathe in the opposite direction because he have the stop. He have the pressure on the right thoracal apex of the curve. Left side, it's free, it have the equal space, and the only way for breathing it's on the left side. So like Nicolas said, the convexity of the curve is going in the opposite side. So same on the left picture, you have the space in the brace, which sometimes it's ugly. The patient is asking to reduce that area, but this have also the function. We are pressing on the anterior side, the distal part of the sternum, to have the respiration guidance on the posterior side. We need to have the more activation of the muscles in the back. That's the space for that. Every part in the brace have the reason why it's something is like that. So from the anterior side, pressure, from the posterior side, respiration guidance. Here you have the picture also in the transversal plane, the example of the derotation. So like we said, on time, it's important to start on time with the brace. When we have the grease, which is let's say approximately 20 up to 25 degrees, more than 30, it's a little bit late, and the 60, obviously it's too late. This guy before had the good results, but this is the example. This is the same case. He had the good planned treatment. He started with the short therapy, and he had the good function of the brace, but he refused the brace and the short therapy. Sometimes it's depending from themselves. So sometimes I'm doing the easy flexible test of the flexibility. I just drove the spine on the back and see in the lateral side bendings what is happening with the particular area of the spine, lumbar or thoracal area. It's helping me to have the better treatment plan, because it's usually that one curve it's more rigid than the opposite one. Then we speak about the primary curve and the compensatory curve. Also from the top picture is showing the derotation of the pelvis and the derotation of the specific area. I could see also here the rotation in the lumbar area. It's easy to make the pictures and to see in the specific area what is happening with the rotation. This is the example of this is the old principle, how you are taking the cast, let's say for the brace. So you're using the gips for taking the measurements. And when I cut the plaster, I noticed one thing, which I will show you. This is the left lumbar curve. Everything is clear, 100%. So this patient who is not going in the short therapy, he's using the weak side for breathing. A strong side for breathing, and the weak side, the right weak side in the lumbar area, it's becoming more and more weak. Why I'm showing this? Identification of the problem. So if you find that the patient will breathe in the curved direction in your brace, so doesn't have any sense to continue with the brace if the patient doesn't want to go in the specific therapy. I hope that you see this. Maybe something is with the connection bad. I hope that the connection is good. So this is our classification. We have just 5 of models of type of the braces. And we said it's according to the functional pattern and the radiological findings. And in those 5, you have 10 because you have always the mirror of the effect. Let's say, for example, this is the left lumbar and it can become right lumbar. So here for the S5 type of the brace, you have 2 types. So from those 5 type of the braces, you have 10. So from my side, that's all. I'm open it for the questions.
Yes, thank you very much, Mr. Matic, for your very interesting presentation. Honestly, this is give me some new perspective in orthotic prosthetic, and
That
for the
was the
prosthetic.
idea.
Yes.
Sorry.
Yes, yes. Yeah, honestly, in physiotherapist. Okay. So
I must say, just also from my experience, from my mistakes in the past, your job is my job. It was to do the brace, and I do the brace, and that's all. Now in
yes,
the multidisciplinary team, we have the same communication. So the doctor is here, the short therapist is here, and I'm here. So for one patient, we make the consultation and make the decision. That's the only way for the good treatment plan. If I'm just do the brace and don't think about it, the short therapy, and make the consultation with the doctor, it's a question of the treatment, what will be.
oh yes, I'm totally agree with you, Mr. Matic. So it's important to collaboration with other profession, especially for with from physiotherapists, medical doctor, also with orthotics prosthetic. So for everyone, do you have any questions? Because in the chat room, there's no questions from the audience.
There was a question about the type of the braces.
Oh, wait a second. Oh yes, yes, I found the question related to the orthotic prosthetic. So, Mr. Matic, it's from Devi Siswani. Is there any difference effectivity between Boston, Milwaukee, and GBW braces in treating scoliosis?
I will just make a smile
Yes.
because there is a
Yes.
big difference. So like we said, for the Milwaukee brace, he's creating the axillar extension of the whole spine, and you can have the lateral correction of the scoliosis, but you will lose also the sagittal profile and the sagittal normal alignment in the lumbar area and in the thoracal area, which is really, really bad to do. So it's needed to stay in the physiological sagittal profile.
Okay, thank you. So there's another questions. Is there any tips for the exercise for the corrections for the optimal uh, s- uh, for optimal exercise for the structural scoliosis with trunk rotation, and also how long the brace is a general use and effective in the daily living.
For sure, until they grown up, so they finish the phases of the after 3 years after the first menage, like the Samra said. There is a couple of main points which is in observation, and for the girls it's something around 17 years old, and for the boys it's a similar. Maybe it's a question more for Samra. I don't know the exactly the age. If the question is in a specific age, when we should quit the treatment and really go out of the brace. So let's say the Risa sign, which is 5, so the skeletal maturity is over. There was a time between the first menage, more than 2 years, and in the checking up there is a good stable situation with the short therapy, then the curve will not progress. I don't have the cases which is older than 17 years old. That's
Sorry, yes.
the border.
Sorry, okay. Sorry, Mr. Matic. So maybe the question is about the how long the patient use the brace in a day. I mean, how many hours? Yes, how many hours
So
is effective for the
it's
people?
depending from the curve. So for example, just don't catch what I'm saying exactly. So for example, if the patient have 20 degrees and it's idiopathic scoliosis, so less risk of the progression, 20 degrees will wear the brace 15 to 16 hours, for example. If the patient have the more than 30 degrees, same idiopathic scoliosis and all other points are the same, but 30 degrees, we said it will wear more than 18 hours of the brace. And of course, in the combination with the short therapy and with the short therapy in the brace.
Okay, I see. So thank you for your
40 degrees
explanation.
will wear 23 hours.
Yeah, so it will be
I'm
depending.
sorry, can I just add something to
Yeah.
what just Luba said?
Okay, Dr. Samra.
Yes, we look at the, like Luba said, curve severity, so the curve angle, but also we have to look at the risk of progression. So if there is a high risk of progression, even if the curve is not that severe, we need to have a full-time brace wearing, because it is important to stabilize and to prevent the progression of the curve. For example, if you have a child 5 years old or 6 or 7, doesn't matter, that has 20 degrees of curve, and you have a child with 16 years of age that has 20 degrees of curve, you will not treat this curve the same way. So in this child that has early onset scoliosis and 20 degrees, this child is in great risk of progression. So you have to go with the bracing. The earlier, like Luba mentioned in the presentation, the earlier you start, the better. And you know that this child is at great risk for further progression. So you will tell this child to wear the brace full time. In the child of 16, 17 degrees, you can even skip the brace. You can try with the specific exercises. And if you see the progression, then you can put the brace on, and it doesn't have to be the full time. It can be less than 18 hours. But curve severity plus risk of progression is what indicates the time of brace wearing. And also when we start weaning the brace, it happens gradually. So we don't put off the brace like the child wears the brace 20 hours and then we say, oh, you're not at risk anymore, you can leave the brace. No, it's a gradual process, the weaning process of the brace, and it lasts over 1 year, year and a half in some patients. So to go from full time to nighttime of bracing to fully to be out of brace. Okay.
Oke, Dokter Samra. So dari pertanyaannya tadi untuk berapa lamanya penggunaan dari brace itu dari Mr. Matic mengatakan bahwa itu tergantung dari derajat dari skoliosisnya. Jadi sebagai contoh di bawah 30 derajat kurang lebih 15 sampai 16 jam kalau tidak salah tadi saya tangkap seperti itu. Jadi tergantung dari seberapa besar dari skoliosisnya. Lalu Dr. Samrajanik menambahkan bahwa semakin terdeteksi awal dan dikomunikasikan dengan penggunaan brace akan semakin bagus. Jadi untuk hasil yang ke depannya seperti itu secara garis besar. Thank you, Mr. Matic and Dr. Samrajanik. And I want yes. And for the last question, okay, it's from Agus Hari Nugroho. From how about if the scoliosis have the apex above the T5? Does the brace still can use to correct the curve?
Someone is asking who is doing the Milwaukee brace. So it's a little bit high for the Zobenheim and for the Schrennel brace. This is a really difficult case, and maybe it's the only way to go with the neck ring with the Milwaukee brace in that case, if its apex of the curve is in TH5. So we are treating also with the Zobenheim brace. We are counting on something else. So if you have the apex on the TH6 or 5, so we are creating the extension below the axillas. We have the special brace, which can help a little bit with the high curves. But it's, in that case, he knows what he is asking. It's a Milwaukee brace. It's doing well.
Okay, thank you, Mr. Matic, for the explanation. So, beliau mengatakan bahwa untuk scoliosis di atas T5 memang agak sulit dan harus ada beberapa tambahan dari brace itu sendiri. Jadi harus di-adjust dan segala macam. Seperti itu secara garis besar. Oke,
boleh bertanya? Iya, ya.
Yes.
Ini yang paling krusial. Aku pakai bahasa Indonesia. Saya mau nanya tentang bagaimana kita bisa dapat brace yang paling efisien tapi murah gitu loh, tidak terlalu mahal. Karena kita tahu bersama di Indonesia tidak semua pasien yang punya duit banyak untuk beli brace berharga puluhan juta. Jadi saya mau nanya ke 3 orang ini, ya, in English. Mr. Matic, so how much the brace for Zobenheim brace that very effective but not too much expensive that we can give to our patient, especially in Indonesia, because almost all of the patient in Indonesia, not almost, some of them they can afford to buy the good braces, but how about those that cannot afford the expensive brace? Because when we talk about the brace comes to Jakarta or Indonesia, it's about expensive, and it's not just 10 million, it's more than that. So we try to make a good way, to find a good way to help them. They cannot afford them. So maybe you can suggest which better option for us. Thank you. So it's very
No, it's not
I don't know.
long question, but I'm thinking that I will say honestly, the material for the brace it's not so expensive. The some specific countries like in the Germany, they are charged and it's expensive their knowledge to make the brace. So the material for the brace it's not expensive. I will not say now precise how much is it,
Okay,
but
I
it's not
know.
so expensive.
Okay. I know. I also already talked about Nicola that now we try to find a good way to connect the good braces, but not too much expensive, so everybody can afford it. So thank you for
Yeah, it's
explaining.
just a
I
knowledge
hope we
to
can
make
find
it,
a way.
nothing else.
If I can add
We
something,
must send. Then we must send some OP to go there to learn how to make a good.
He
Yes,
will
yes,
come.
exactly,
He
please.
will come here.
exactly, Susan, that is the great to have person who will be trained and educated by instructor, and to start to to make the brace in Indonesia. That's the best option. As also we mentioned for the doctors, that will be the perfect way to have educated doctors in this way, in short way, and also to have, that is the way how you can go step by step to make the multidisciplinary team. Educated orthotist, educated physical therapist, educated doctor in one country, in one city, in one place. That is the best option because no, patients will not be confused because we are talking to each other, between each other. Samra, Luba, me, we are talking and we are exchanging the experience what to do. Sometimes we are making mistake, and that is why we have Samra or Luba to correct that and to say, okay, we will do that in different way. That is what does it mean multidisciplinary team. But you need to have specialists in your country who will be trained and with good experience during the time to make the brace. And after that, brace will not be expensive because someone will make the brace from your, maybe will be in your neighborhood.
Maybe.
Yes, that's right. Okay. We can try, find a way. Okay, we will talk about it with some colleague here. I think they already have a good mind here because you already explained in a good way. Thank you.
Welcome.
Galuh,
Is
masih
that
ada
all?
satu pertanyaan. There's one more question, Galuh, please.
Oh, aku kira udah 3 pertanyaan, Mbak Susan. Oh, yes. Oke, di ini ya, di buku saja. So, the last question, Mr. Matic. So, what is the main purpose give a pressure on sternum in your brace? Is it a part of breathing guidance as well as on the lateral pressures?
No, it's just a pressure for the respiration guidance on the posterior, so dorsal side of the back. We are creating the breathing function in the back.
Oke, dari arah posterior.
Just a second.
Yes.
So this is the function. The pressure in the distal part of the sternum, it's not too big pressure, it's just a respiration guidance. So it's holding the sternum to not going in the front and the anterior side, and it's creating the opposite results that the patient have the possibility to breathe in the posterior area. So the patient is creating the activation of the muscles of the back. That's the task from the sternum support.
Okay, I
So,
see.
with the neurological cases, we also can use this method of bracing.
No, just for the idiopathic scoliosis.
Idiopathic scoliosis.
Yeah.
Oke, jadi Pak Johannes Purwanto, jadi ini digunakan untuk hanya idiopathic scoliosis dan untuk mengaktifasi otot-otot bagian posterior juga dari penderita scoliosis ini. Oke, terima
So,
kasih.
Mr. Matic, one more. So, what's the base brace for the neurological cases?
I don't know exactly. It's depending from the case, and it's depending from the muscles. It's depending from the lateral deviation, and it's depending from the functional patterns. Let's say how the patient is creating the walking, the sitting, and so on. For the neurological braces, usually we do just the support. So we are not creating the big pressures and the big expansion zones for the throat therapy. We're just holding the spine like a support.
So, most likely, like what kind of shape of bracing?
It's almost symmetrical. It's almost symmetrical.
Okay.
Yeah.
Oke.
Okay, thank you.
Oke, Mbak Susan.
Ya, sudah jelas.
Okay. So I think for the last, thank you, Mr. Matic, for your presentation and your valuable insight for us. So I think we are good for now. Thank you, everyone, and thank you, Mr. Matic. It was a pleasure being with you all today. And for the last, I will give it back to the host, Mbak Dina. Mbak Dina, go ahead.
Okay, thank you, Mr. Galuh. And the last, thank you for our moderator, Mrs. Susan and Mr. Galuh, who was the even interesting, isn't it? Hopefully, on another occasion, we can hold a event like this again. We have come to the end of our webinar. I would like to thank everyone who made this meeting possible. And thank you for our speaker, Dr. Samra, Mr. Nicola, Mr. Zubomir, who have shared a lot of knowledge, and the presentation is very and thank you all once again for coming. When speaking is not good. And you see you in our next event for all of and I am Dina Wijaningsih. See you next time. Thank you.
Bye
Okay,
bye.
just want to adding some. I like to thank to my colleague from Malaysia. They the most OP participant that joined in our webinar in Malaysia. So thank you for your time, and I hope we can do some. I don't know where to go to training because actually a few years ago, me and some friend, Dr. Sam, trying to make the training for the OP here in Indonesia, but because of the regulation and the fee to doing the training is so much expensive. So maybe Mr. Matic Jubamir can find a way to come to Indonesia to give us some training for the OP, or some of the physio can see how the OP doing the bracing stuff. And we hope, well, everything is about the money. When you come to Indonesia, it's a good view, but we don't have so much money. So we have to make a good package of that. So thank you for your time. And thank you for Dr. Samra also and Nicola.
Thank you.
Yes, thank you, Doctor.
Thank you, Susan.
So I'll see you all next time. Thank you, Nicola.
Thank you
see
so much. Thank you so much.
This Saturday. Yes.
And I hope that we will see
Zoom.
each other personally very soon. I'm looking forward to come again to your very nice country. Maybe we'll come all of us together. Who knows?
Who
Oh,
knows?
okay. We'll try to, but for sure, next year will be the next level 2 of group first, and we try to open the registration for group 1. We have to reconnect again about the regulation and everything. So all be safe, stay away from COVID-19, and thank you. Good
Thank
night,
you.
everyone.
Bye.
Bye
Thank
bye.
you. Bye. Bye.
Bye, thank
Thank
you.
you, Dr. Samra.
Terima
Bye.
kasih
Thank you
untuk
everyone.
semuanya. Mas
Teman-teman
Susan,
kalau
Mas
masih
Galuh,
ada,
dan panitia.
ya,
Makasih
kalau masih ada
banyak.
pertanyaan bisa taruh di grup WhatsApp ya.
Terima
Bisa
kasih Bu
taruh di grup
Susan.
WhatsApp ya untuk pertanyaannya. Sama-sama.
Selamat.
Dokter Maya.
Senang banget
Iya.
ikut. Makasih banyak ya.
Iya. Siapa tahu boleh buka pusat rehabilitasi khusus postur ya, Dok, di sana.
Ya, nanti usul ke Dokter Vini. Beliau nanti jadi
Asik.
spesialis
Asik.
restorasi.
Iya, bagus.
Ada ikut beliau
Good.
di sini. Iya. Iya, makasih
Iya,
banyak.
boleh, Dok.
San. Tuhan
Sama-sama.
berkati.
Nanti bersama-sama. God
Iya,
bless.
God bless.
Ditunggu informasinya terkait PO ya Bu Susan.
Oh iya, lagi cari cara karena dia punya training lebih mahal dari Scratch. Jadi itu sebenarnya tahun-tahun kemarin kita udah nanya-nanya, cuma masih lagi mahal, makanya nggak tahu mau bagaimana caranya supaya nggak terlalu mahal.
Baik.
Gitu.
Terima kasih Bu
Oke.
Susan.
Thank you.